Hey class, so this screencast is on classification and treatment plans. Again, just like assessment, I kind of go off the book a little bit and kind of do my own thing here, just to talk about this in a little different way. So, this picture right here is of Traverse City State Hospital. In this hospital is closed. Now it's actually luxury condominiums. And my great grandmother apparently worked there. I obviously didn't know her, but this building, this facility, it was like a little city. And they had a power plant, farm, and all these different buildings. Think of it like a college campus. And that's where people would go for psychological treatment. Well, I'm sure that by now in your classes you've talked about deinstitutionalization and how these facilities are really no longer. Each state will typically still have a state hospital, like we do here in Wyoming, but it's reserved for treatment of serious mental illness. So I want you to think about where we've been with treatment of psychological disorders and where we are now, and if we're doing any better. So classification and treatment plans. Now, one thing that I'll use is I'll try and use the term client and clinician. Client is a term that we use instead of patient, and that is a directive from the American Psychological Association. Now, clinician can be all sorts of different people that work with clients, whether it's a social worker or a psychiatrist, but um, what I want to differentiate between is psychologists, and then we'll talk about psychiatrists a little bit in a second. So you can use the term clinician for just about anybody, but client is a person that's seeking psychological services. So think about client is more of a collaborative term versus calling somebody a patient. Patient um, gives the impression that the person is passive in the relationship and inferior too, where if you use the term doctor instead of clinician, it kind of sets up superiority. So in the psychological world, we like to differentiate between the medical community and use the term client to indicate that it's a collaborative relationship and that the person is active in their treatment. Now, different facilities will use different terms. For example, I worked at a state hospital in Florida, and we seriously had to use the term persons served instead of client or patient. So, a clinician is the person that's providing treatment. Psychiatrists, you should know this already, but I want to review it. Psychiatrists are medical doctors that have training in psychology and in medication. And a psychologist is a mental health professional with training in behavioral sciences who does therapy or assessment or consultation. So there's two types of doctorates in psychology, a PsyD and a PhD. PH is for philosophy, and the D is for doctorate, obviously. So PhDs focus more on pursuing an academic or teaching career, and much of their training will involve research. So most PhDs will do dissertations and take a lot of classes in statistics. You can do clinical work with a PhD as well, but it also trains you for academic and research work as well. A doctor of psychology, or PsyD, is more focused on clinical work. So some PsyDs do a dissertation, some do not. It all depends on the program. If you just want to do therapy, then you could go the PsyD route. It's typically a little shorter. And it's not like teaching is limited to PhDs. If you go to a graduate program, a lot of the faculty there are PsyDs actually. But research psychologists overwhelmingly are PhDs. There's a copy of my dissertation, or not my diploma, if you ever wanted to see it. So last time we talked about reliability and validity in terms of assessment, and I want you to remember that one word for reliability, which is consistency, and then validity. So we talked about validity being accuracy in reference to a test. Does it measure what it purports to measure? Well, you can have reliability and validity with diagnosis as well. So one thing that I always talk about is with my general psychology students when I'm trying to teach them about reliability and validity is, what if I decided to use a bathroom scale to measure IQ? So could we use a bathroom scale to measure how smart you are? And I want you to think about that. Is that reliable? And is it valid? And take a moment to think about this, because this is actually a little tricky. So I'm okay with this. I mean, I'm pushing. Oh, maybe I'm probably 185 right now. I like that. That's a nice high IQ. But you might not like your IQ score based on this. But I'm trying to make jokes. But is that reliable? Is it valid? So answer that. Is it reliable? If you said no, well, you're actually wrong. Because reliability means consistency. And if we were to try and measure your IQ with a bathroom scale, we'd get the same consistent score over and over and over again. There might be some variation, if you weighed yourself at night versus a morning or something like that. But for the most part, you're going to get consistent scores. So it is reliable. Is it valid? Oh, absolutely not. That's ridiculous. It's not accurate at all. Is there an accurate measure of weight? Yes, very accurate. But is it a valid measure of IQ? No. Okay, so right now, what we use to make a diagnosis is the Diagnostic and Statistical Manual of Mental Disorders, which we call the DSM for short. There's been a number of different DSMs, and this book is published by the American Psychiatric Association. I want you to note that that's psychiatrists, not psychologists, and that it's just kind of interesting to point out. So the medical community puts this together, and the advisory board is overwhelmingly MDs, and there's a handful of psychologists that help put this together. But what it does is it standardizes the terms that are used for diagnosis. So when professionals talk to each other, we know what one another are talking about. And it defines the psychological disorders, and it breaks down the syndromes or disorders into symptoms. And so basically it's a checklist of symptoms. Here's the DSM-5. It's a little blurry there, but that's the version of the DSM that we're on now. And there's been some controversy with the DSM-5. If you're interested in that, just Google it. But there's a long list of DSMs that have gotten us to the point that we're at now. So, there's also the International Classification of Diseases, the ICD, and we're moving into the 10th version of that is published by the World Health Organization. So both of these things are the ICD almost overlaps with the DSM. Not quite, but close. This class, we could have the DSM as like required book for the course, but I'm not going to do that because it's really, really expensive. It's like $180 some, and I don't think you need to buy that. Unfortunately, University of Wyoming does not have access online to the DSM, but a number of the community colleges do. So if you happen to have online access to the libraries at any of the community colleges, it's worth checking out. I know Northwest College students have access to the DSM online. So you would go to your library resources like A to Z or a list of databases and go to P, and it's Psychiatry Online. And there you will have an online version of the DSM. So as we get into the different disorders for your class, I'll just post the DSM diagnostic criteria for the different disorders. So in the diagnostic process, what we do is, we look at the different symptoms that the individual presents. Symptoms typically cluster together and represent a syndrome. So we hopefully know what we're doing, and we recognize the clusters of symptoms as they occur together, and go to the DSM, and typically it'll say, this disorder is indicated by 5 or more of the following. And then it's just a checklist. And so as a clinician, you need to identify what the principal diagnosis is, or the presenting problem, and that is a primary reason that the individual is seeking help. But then we use the term comorbid to describe multiple conditions that occur simultaneously. And so sometimes you'll screw it up. You'll have a primary disorder and a secondary disorder, and what do you focus on first? That's always a question that people ask, and usually it's a primary one, but not always. And then the process of differential diagnosis is the process of systematically ruling out alternative diagnoses. And one way that we look at different cases and look at the etiology or causes of potential disorders, instead of just doing like the checklist and here's the diagnosis, is a case formulation, or why that person is the way they are. We can also do cultural formulations, which we look at the degree of identification with the culture of origin and that culture's beliefs about specific psychological disorders. And in some cultures, different interpretations are going to be in place of different events, and we need to identify what is normal and abnormal in a different culture, and what cultural supports are available to the client. So what we do with treatment is we plan the treatment. Hopefully we do this in advance. A lot of people that are in the treatment world, I don't like saying this, but I know they do it, and they just kind of wing it. They do whatever they feel like doing that particular day. So it could be just having somebody in and talk, and you don't do much, which is fine. There's nothing inherently wrong with that. Just making up your own treatments on your own, that's problematic. But you should have a plan for how the treatment will progress, an outline for how therapy should take place. And at the onset, you should have goals for treatment. So if you know that you meet those goals, then treatment's over. But if you don't have goals at the onset, how are you going to know when you're supposed to stop treatment? It could be immediate goals or short-term goals or long-term goals, but how do you know when treatment has been successful? I should make a side note here that you should do assessment as you're looking at treatment goals. So maybe it's a 50% reduction in symptoms of depression, or 80%, something like that, that's quantifiable. So if what you're doing is working, and if it's not working, you got to do something else or refer them out. So you got to also determine the appropriate site for treatment. That might be psychiatric hospitals. That's usually reserved for serious psychological illness, like if somebody is an immediate threat of physical violence to someone else or themselves, so homicidal or suicidal. There's special inpatient treatment centers, like, for example, substance abuse treatment centers. Most of therapy in the United States is done in outpatient treatment centers. There's also day treatment programs, halfway houses, stuff like that. One thing to be aware of living in Wyoming, like I do, is that there's a lack of psychological services that are available. So in your community, you might not have access to a lot of these things. So, what happens when somebody needs psychiatric hospitalization? Well, where I live, they would go to Evanston, which is about, I think Evanston's like a 5 hour drive away, which is a long ways away. So you got to know the treatment sites within your community, and hopefully that'll work out. But sometimes different treatment sites will be necessary. So there's one of the hospitals that I used to work at. This is South Florida State Hospital, and I just wanted to put this in the lecture because this hospital is owned by a company called GeoCare, which is actually one of the largest private um, jail and prison companies in the world. So they're in the corrections business. The other one is Correction Corporation of America. So GeoCare has moved into the psychiatric hospital business. So they contract with the state of Florida, and they can provide services cheaper than the state of Florida did. I'm not sure if that's necessarily a good idea. I want you to kind of think about that one a little bit. Here's this is Wyoming State Hospital in Evanston. It's a nice facility. It's new. A lot of these facilities have been rebuilt because the old facilities were not nice and were not new. So those are some of the different sites. But again, most treatment happens in outpatient settings, in a private practice or community mental health center. So that leads us into the different modalities. So you can have individual therapy, family therapy, group therapy. For children and adolescents, you might have all three of these things. So you have to determine what's appropriate. One thing that I like to note is it's not always possible, but I think it's best if the individual therapist and, say, like the group therapist are different people. Or like you don't want, like, if you're seeing like a mother and the two children, you don't necessarily want like one of the individual therapists to be the family therapist because of conflicts of interest. So when we look at treatment, a lot of people kind of ask around this time, well, how do you know what you're supposed to do in treatment? And, well, there's a couple answers to that. One, that's what you go to school for. So if you're going to be doing therapy of any sort like this, you should probably head off to grad school. An undergraduate psych degree isn't going to prepare you for that, which is unfortunate. Maybe that'll change someday. So, but you got to go to grad school, and they'll teach you how to do therapy. But even then, and I like to ask grad students, how do you know what you're going to do with that individual? And sometimes you just kind of know. You intuitively know. Maybe you base it on your clinical experience. You've worked with clients like that for 20 years, and you just know what to do. Well, that's good, and that will likely work in most cases. But you should base what you're doing on research, and that's what we call evidence-based practice. So you make clinical decisions that integrate the best available research evidence. And what we're talking there is you go to the journals, you go to the literature, and you look at what studies indicate what treatment works best for what disorder. So, what works best for ADHD? In some of your posts, you identified that medication works a lot better than therapy in the treatment of ADHD. Well, you gotta take the research evidence into consideration. Even if you don't like that personally, that's your own bias that's getting in the way. Now, obviously, I understand that medicating children is controversial and problematic and all the negatives that are associated with that, but if the research said that family therapy works best to treat ADHD, then you gotta listen to it. If it says that playing with horses, equine assisted therapy worked the best, well, then you gotta look at that. You have to look at individual studies and you have to critique them and you have to understand strengths and weaknesses of research. And it's not going to be based on just one study, but you look at the body of evidence, and that will help you make your decisions in conjunction with your clinical expertise. And people that come to you are not going to be the same as research participants. People are going to have multiple problems. You're not going to find research studies on, I don't know, 16-year-olds with ADHD and substance abuse problems whose parents are in the middle of a divorce that are having academic problems and their boyfriend or girlfriend just broke up with them. You're not going to find a research study on that. You got to look at the individual as well and their preferences for treatment. Also, cultural background, that's very important. So, once you begin treatment implementation, the course of treatment, you have to define what the course of treatment will be, hopefully in advance. You might not say, like, well, it'll take 15 sessions to figure this out. I mean, you'd want to give somebody an estimate. And then you'd want to define the clinician's role in treatment, like what you're going to be doing, what the client's role is in treatment, whether they're going to be active participants or not. Hopefully they will be. And what the planned outcome for treatment is. So you need to identify that in advance. And that way you'll know when treatment is successful, when to stop. All of these issues are important, and this is just a brief introduction to treatment. Obviously, when you go to grad school, that's what a good majority of your training is. So you'll have what they call practicums or internships or different training experiences where you'll learn how to do this stuff under the supervision of someone else. So that's it. If you got any questions on this stuff, as always, feel free to email me.